Колеги, честита нова година! Добре дошли! Знам, че ситуацията е тежка в момента. Голяма част от колегите, които поканихме, са или болни, или под карантина, но и в тия трудни времена ние се опитваме да създадем условия за провеждане на мероприятия като това. Те ще бъдат множество през тази година, живот и здраве, разбира се, и следейки ситуацията с COVID в момента, се опитваме да адаптираме мероприятията към сегашните условия. Имаме две изненади за вас днес и утре, надявам се, за част от вас. Първата е това, че ще бъдат поканени всички колеги в новата клиника, която се казва Спектро има. И втората ще я запазя за малко по-късно. Имам удоволствието днес да ви представя нашия лектор, доктор Ли Уокър, който е орален хирург от UK, един от основните тренери на Teoxane. Вярвам, че днешната му презентация и демонстрации, както и утрешната част, ще бъдат интересни за вас. Ако имате въпроси, можете през цялото време или по време на демонстрацията да го прекъсвате и да задавате въпроси. Идеята е да стане интерактивна среща. И така, добре дошли, няма да губя повече време, започваме. Доктор Ли Уокър.
Thank you. I think I've got this. Okay. Thank you. And it's an amazing time again to have the opportunity to be able to speak and share knowledge with you all. I'd like to give a special thanks to Teoxane and also Spectro and the Institute of Medical Aesthetics for this fantastic opportunity. I'd also like to express my gratitude for you turning up today because COVID has made things very, very difficult. And I appreciate you being here. It shows me how professional you all are. The flow of today's session is looking at beauty ideals and then moving that through into anatomy assessment, part of your treatment plan, how you choose your right tissue layer and how you choose your product. So we're going to go on quite a long journey. The second half of the presentation is based around the periorbital area. So we're going to look and have a very deep dive into the periorbital area. So we'll start and we'll look at facial assessment, beauty and aging, because I think that if we don't understand this part of our assessment, we tend to get things pretty wrong. So there are four concepts of facial beauty, and these are symmetry, averageness, youthfulness, and sexual dimorphism. And I'll explain what those are in a second. Symmetry is not always about being perfect. It's about being slightly imperfect, in fact. So all of our patients are not going to be perfectly symmetrical. I think that there's only one area of the face which needs to be completely symmetrical, and that is the lips. Everything else can just be slightly asymmetric. And we'll look at this in a bit more detail. Averageness is one of those things where you don't want to be average, you want to be very good or excellent at something. Averageness in facial beauty means that you just conform into the mean of the population. And an example of that would be if you had a very, very long nose, you would be away from the average. And you're classed as not being attractive as somebody else. Youthfulness is what youthfulness is. And this is about having a very young appearance without lines, shadows. And Disney have this very right with their characters, like Frozen characters. No lines, beautiful skin, large almond eyes, beautiful lips, small pointy chin. Sexual dimorphism is what makes a man and a female a female. And we'll look at these concepts in a bit more detail. So let's look at youthfulness first, and we have this transition. Can we drop these lights down a little bit so we can see the screen a bit better? Youthfulness is the journey from being youthful to aging through the decades, and how do we get there, and how can we reverse some of these aging changes? Because this is a journey that happens throughout our lifetime. We will age in a very unique way. And this is a publication by Dina Wan from the US, and it shows us how this aging progression is begin to be manifested on our patients. And what we can see here is that the periorbital area is the number one or first area of the face to show visible signs of aging. And these visible signs of aging occur around about the age of 27. So it's relatively young we're starting to see, and then we see the progression with the mid-face. When we look at the periorbital area in a bit more detail, you're going to see that there is a unique link between tear trough and mid-face volume. What this leads to over a course of time, and Lisa Donofrio, again a publication from the US, shows us that the face will begin to form what we call hills and valleys. And this leads light and shadow onto the face. And here you can see that there are areas which are hills, and then series of darker areas here which are the valleys. And we're going to look at that in a bit more detail when we look at the mid-face, because not all of your face will atrophy. In fact, some of it will grow. So we have this balance between atrophy and hypertrophy. And it's interesting to know what we lose and what we gain. If we understand what we lose, we can replace. So it begins to become an evidence-based approach on facial aging and beauty. What we have with this aging phenomenon is a change in facial shape. And you can see here that the most desired shaped face that we have is an oval, followed by a heart-shaped face. The least attractive facial shape is a square face, especially on our female patients. And as you can see, as we age, the facial shape changes. And how does this happen? And what does it lead to? Well, these are the classic 5 manifestations of female aging. And they all begin with the letter D. So it's disproportion. So we'll have an asymmetry or a marked asymmetry between the sides. We have a deflation and a descent of the soft tissue envelope. We have a phenomenon called dynamic discord, where we lose our facial fat and the muscles can then pull onto the skin unopposed, creating these large radial lines on the face. We have a deterioration of the skin. And we also have this classic defeminization. And in our female patients, this will look like a square jaw, or turning from a female into a male, or from an oval to a square. Remember that facial aging affects every tissue layer. And that's important, because for many years, most aesthetic practitioners would only treat one tissue layer, and that would be the deep layer. We understand that we lose bone, deep fat, we have changes in the muscle, the SMAS, the ligaments, the superficial fat, and also the skin. So the more layers you can treat, the better your aesthetic outcome. And the reversal of those aging changes is going to be so much better. So especially with the mid-face, we have a fat pad deflation, a redistribution of the fat. We have resorption of the bone, a loss of support, and this leads to the heaviness that we see. And this leads us to vectors. And we're going to look at vectors in a little bit more detail when we look at the periorbital. What a positive vector is, basically, is light onto the face. So no shadows. A negative vector is when we start to see a deflation of the deep fat, a loss of support from the bone. We start to see the mid-cheek groove, the tear trough, the nasolabial folds. And we'll show you the importance of this. I think, is the light going to be turned down? Are we going to turn it down? Okay. Sexual dimorphism, I think this is a really important aspect, because you want to make a female female and a male male. And I think that the more masculine or more feminine you are, the more attractive you are. And again, lots and lots of studies tell us this. And it's about what makes a man and what makes a female female. There has been lots of evidence placed around gender specificity with patients and how we follow these. Here you can see the very marked differences when we have a split face between the female and the male face. So placing on dermal fillers strategically will help us make our patients more feminine or more masculine. And an example of this would be the mid-face. The mid-face of our female patients is about subtle angles and curves. It's never about sharp angles and shadows on our female patients. This is because of the fat distribution. The fat distribution in the female face is 2:1. So it means we have twice as much fat in the anterior face than the lateral. So again, with your dermal fillers, you can begin to feminize your patients by placing your dermal filler more anterior. So your focus for your female patients is more anterior projection. Conversely, the male patient is all about the zygoma. And again, if you can look at my zygoma here, it's more emphasized than my anterior mid-face. And my volume would stop around about the lateral canthus. And this is a guide for you with your patients. You can stop here on your male patients. Anything more medial to this, you're beginning to feminize. The fat distribution on our male patients is more of a one-to-one relationship. So if you want to make your female patients more male, give them more zygoma. If you want to make them more feminine, give them more anterior volume. And we always have to consider gender, because if we don't consider what we're doing, then we can begin to make changes which don't look great. So this is a UK reality TV star, and she's very, very attractive. And people start placing filler in some very strange places, and you end up having a beautiful female into an angular male. I don't think this, personally for me, is attractive. This is that sexual dimorphism. It's the movement away from the female towards the male. And we've moved her away from the averageness. And we've made her look older. So these key concepts of beauty, they're being violated here by practitioners. Now, some of you, not all of you, would think, I quite like this. Beauty is incredibly subjective, but there is objective measurements to beauty. So that's a consideration on placing filler without a consideration. So when we do our assessments in both frontal, lateral, static, and dynamic. And that's incredibly important because your patients tend to see themselves from the frontal view, and we will see them more from a lateral perspective. So what gives the face its shape? Again, it's metrics, it's numbers. And here we have 3 measurements, the bitemporal, bizygomatic, and bigonial width. And generally on your male patients, these tend to be pretty much in a straight line, with the emphasis on the gonial width here. On a male, it's so much bigger. So that tells you straight away that on our female patients, maybe increasing their gonial width is not a great idea, because it's going to make your patient look masculine. And remember, the older your patients get, the shift in volume goes from the zygoma to the gonial. So that tells you that maybe on your older patients is to move the volume back to where it was, in the temple and in the zygomatic areas. Your skull will dictate a lot of this. The bone will set the tone. And here you can see very, very different shaped skulls dictating facial shape. And again, you can manipulate soft tissue for the appearance or the illusion of a narrower or wider or shorter face. What we do have is evidence now which is beginning to show us that some of these measurements we can do will give us what we call classical global beauty. And this classical global beauty, it doesn't matter what ethnicity you are. If your face fits into a certain parameter, you're attractive. And we use what we call the oval face. This is the most desired face. And this is what it looks like. So each part of our face should touch this oval. Anything outside the oval, you're going to make your patients look strange or very alien. So your temple, your zygoma, preauricular area, gonial width, angle of mandible, and chin should all fit inside. So how do you do this on your patients? It's pretty easy. You measure the intercanthal distance. You times it by 4.3, horizontal, and 6.3. And that gives you your facial oval. You can see here that my friend and colleague, Dr. Tony Burke, has made herself look a little bit strange. She's placed areas outside of the facial oval. So, we have to take this into consideration about creating a face which is too wide or too long. And we'll look at what these changes mean and how we create these changes as we move through. So what do we use? Do we use thirds, fifths, or the golden proportion? Do we conform to formulas? Some of you may have those wonderful golden calipers where you measure people's face. And I use this as an example because these are a very beautiful couple, Angelina Jolie and Brad Pitt. And we can begin to measure objectively. But should we use formulas? Should formulas be used, or do we have an artistic eye that tells us which something is beautiful? Let's have a look at golden proportion, because you hear this so many times. 1 to 168. So this is Angelina Jolie and this is Brad Pitt. Now let's put them into golden proportion. Let's use mathematics to put their ideal proportions in. That's what Angelina Jolie would look like in golden proportion. That's what Brad Pitt looks like. So maybe we shouldn't be conforming to formulas, because it's not ideal on some people. There is lots of other considerations to take into effect. So again, here's Tony, and what you will see here is her face begin to change. And this is our patients as we start to add filler without consideration. We just start to add, and we use Teoxane, and we have lots of strange things, and now we have a pretty strange face. It's not that oval face that she had at the beginning, it's more of a diamond-shaped face. We've increased her facial length, we've increased her zygomatic width, the volume of her lips. So what's happening? How do we move from here to here, and what are the changes that you're likely to see? Well, increasing the lateral brow height. Again, this is something you don't want to do on a male patient. Female patients may ask for this. We've got medial brow depression. We have a reduction in the apparent eye size and an increase in the canthal tilt. So it gives this appearance of a smaller eye, which is a masculine appearance. We've got more anterior mid-face volume, an increase in bizygomatic width, an increase in the volume of the lips. And we're going to look at volume in a second. How much is enough? We've increased the bigonial width, and that's the last thing you want to do on your female patients, because you're going to make them masculine. And we've accentuated a chin, and we've lengthened the lower third. So we've taken her face and we've moved it outside of that female facial oval. So how much is enough for the lips? So we have very thin lips and very big lips here. And this was a study. I read the original article as a poster in 2011 from this author. And this is Natalie Popenko from Canada. And what we have here is an objective measurement of volume. Now, the volume here will surprise you, because some of you are looking thinking, oh, I quite like this one. What lay people, or so your colleagues or your friends or your family would say is the most attractive is just a 50% increase. That is the most attractive lip to both medical professionals and lay people, so people in the street. So maybe less is more with the lips and keeping things as natural as possible. Staying on the theme of the lower face, I've discussed with you the gonial width, so the width of the mandible. And what we have here is quite an interesting thing. It's the actual angle now that we're going to look at. And what we can see here between the angle, it's very close between men and women. So there's really not a sexual dimorphic difference between a man and a woman's female angle. These are those angles on some of the most beautiful women in the world. Now, what's interesting about these angles here is that they're obtuse angles. And now in a large internet study conducted for males, the most favorable angle for a male is 1 to 8. So again, you would class that as a female angle. Remember, this bigonial width is something that you don't want to increase on your female patients. And I know that some people give this nice bolus into here, but the more bolus, the more product you give, the wider your patients are going to come. And this is what you're starting to create. You're starting to create a masculine face. And this can creep up to you very, very quickly, depending on the volume and depending on the amount of visits your patients have. So this, for me, is a more attractive side of the face. The other side looks too masculine. So sexual dimorphism. Symmetry. Which one of these models is more attractive to you? The left or the right? Everybody's really quiet. You must be. You like this one? Put your hands up for this one. Okay? Okay. Put your hands up for this one. Okay. So this is really interesting, because some of you like symmetry. So this is the two half of the face put together, and this is asymmetric. And more people are looking at the asymmetry. This is for the ladies. Which is the most attractive? Maybe the men. Which is the most attractive George Clooney? Left, center, or right? Right, hands up for center. Okay. You two are obviously friends. Yeah. Hands up for left. Yeah, that's really interesting. Because again, the perfect symmetry here is center. So you've moved away to the asymmetric George Clooney. So that's what I was saying at the very beginning, that symmetry is not always attractive. It's okay to be imperfect or not perfect. Lateral view. This is, I think, one of the most important aspects of facial beauty and profile. And my background in orthodontics, facial development growth, and orthodontics, moving the jaw and teeth about, give me a really good insight to this. And it's very, very helpful. And here we can see, without making things too complicated, we have what we call a class 1, a class 2, and a class 3. So this is normal proportions here. This is a retrognathic or small chin, and this is a prognathic or large chin. And it's normally set by not the soft tissue, but by the bone. And a really nice example of this is facial attractiveness, is this. And this is something you can all do within your clinical practice. You can use this line here, it's called the zero meridian line. You just drop a vertical line from the nasation all the way down. And if your chin is behind the line, you treat the patient's chin with some fillers or an osteotomy or a chin implant, because your chin and lip should be anterior here. So this patient would require chin and lip projection. So using these very, very easy lines, soft tissue profiles to use, it's very useful for your patients, because Instagram, social media is a big driver of profile. Patients are very, very aware of their profiles now. Well, what we have, again here, is a masculine face, wide gonial width, acute angle here, moved to a reduced gonial width and an obtuse angle. Yes, it's extreme, but it shows you the difference in sexual dimorphism, not from the frontal view, but from the lateral aspect also. So making our patient more attractive, moving away from the square to the more oval. Again, oval face, oval-shaped faces are more attractive. Again, you have to consider, as part of the beauty, ethnicity. And here on, for example, on an Asian patients have a wide bizygomatic width. They have a wide gonial width as well. So here would be something very simple to just reduce the masseters using Teoxane, but not to increase here because they're already very wide. Your augmentation on these patients and any patient with a square face, if you want to make the face look thinner, you add volume anterior. This is very, very important. So here, anyone with a square flat face needs anterior projection and never zygomatic projection. This is how you change those beautiful facial shapes. Keeping on the theme of placing filler in very discrete and specific areas, you can see the importance of lateral profile here. So here on this Asian face, we have a retruded maxilla, we have a retrognathic chin. We also have a deep radix onto the nose. And again, making changes with dermal fillers really does have a huge impact. And you can see the impact here on this is a negative vector. We're going to discuss this in a bit more detail. We've now created a positive vector. And again, with the chin. Huge differences in beauty on these patients. But look at the lid cheek junction with that anterior projection of the mid-face. we've reduced the severity of the tear trough. So facial shape is really the key to universal beauty. It doesn't matter what ethnicity you are. This lady here is Japanese, this lady here is Korean. You can see, very different, but you can see the shape of the face in its oval shape. It gives a more beautiful appearance. And again, that's specific to our patients. So that's facial beauty, harmony, symmetry, ID. And we're going to put this into context now of something we call ATP. ATP is really the foundations on which your clinical practice should be built. And what is ATP for those who don't know? ATP is anatomy, aging, and assessment. Your T is your technique, and this can be with a cannula or a needle or a combination. That's up to you. You have ownership of your own technique and your product choice. The right product in the right tissue plane gets you the right result. It's very simple. And that's what we're going to do today. We're going to keep to these key concepts of ATP. I want to introduce you to the concept of facial layers. Facial layers are incredibly important because it gives us the opportunity to do two things. One is to avoid the vasculature, which will run in these specific planes, but also which of these planes ages more than the other. So again, we'll look at this in a bit more detail because sometimes you don't want to treat the superficial fat. Sometimes you'll only want to treat the deep fat here. So this is that classical anatomy here of facial layers. Now your facial layers are different across the face. Here you can see in the chin, jaw, mid-face, nose, and eye here, forehead, you have 5 layers. In the temple, you have a contested 10 layers, and at the angle of the mandible, 7, because we have the parotid gland and the masseter muscle here. Your tear trough only has 3 layers, and that's a problem. And we'll look at the problem when we look at the periorbital area. That's the number one reason why we have so many complications with the tear trough. It's the lack of layers. So we're going to use ATP, the anatomy, assessment, and the aging, and we're going to look at the mid-face. But we're also going to keep in the back of our minds beauty. So you can see the arrangement of the fat between the young and the old face. And you can see there's a redistribution, a change in shape and a change in volume of this superficial fat. So how does the face age? It's not very easy. It's incredibly complex how our face ages. We start with the bone, and you can see here there is a change in angle. And basically, your maxilla is moving in a posterior direction. So as your bone is going backwards this way, then your soft tissue begins to fall forward and create this ptosis, this heaviness. And this is really accentuated or made worse by the fact that you have a line of ligaments here. And the lateral part of your face is static. And it's static for a reason. Because lateral in the face, we don't have any muscles of facial expression. We have muscles of mastication, and they need big ligaments to hold them in their industrial position. Everything begins to move forward because the skull is moving back. We continue the theme of movement or mobility with the fat. Here when we're young, our fat is in these sorts of positions, and as we age, we have a redistribution. So the fat changes shape. And what that redistribution looks like on a face is, on the youthful face here, we have the deep fat and we have the superficial fat. And we have this beautiful positive vector. And as we age, what we can see here is an atrophy of the deep fat and a reposition or a redistribution of the fat from a horizontal to a vertical position. And we can look at this in a little bit more scientific detail using MRIs. And what you can see here is the nasolabial fat, the middle and the lateral cheek compartments begin to redistribute their volume as we age. Now, this mid-face descent has an impact on the lower face, has an impact on the jowl. So again, these aging changes will affect different anatomical units. These discrete fat compartments, and this is the superficial fat of the face, are highly dynamic. And this is important for you to remember, is that you will have two different planes in your face. You will have a static, non-mobile plane, and you'll have a highly dynamic area. You cannot place static filler into these compartments without your patient looking strange. And we've discussed in detail about beauty, harmony, youthfulness, symmetry. So, from the evidence, we're beginning to form a picture of which superficial fat compartments we can target and which superficial fat we need to avoid. So this goes back to the hills and the valleys. Here, your nasolabial fat will increase as you age, so we don't inject the nasolabial. The jowl fat increases, so we avoid the inferior part of the middle fat compartment, we avoid. And again, we begin to have specific targets that we can aim our filler at. Your deep fat, I would suggest to you, is the most important fat for you to target with your filler. The deep fat is attached to the periosteum, and therefore it is immobile. It will move when your bone resorbs. Your deep fat will provide you with the structure and the support of your face. Your deep fat will continue to atrophy as you age. This is key to a beautiful, youthful cheek. You need to treat the deep fat. Here you have your deep fat compartments, which are medial souph, lateral souph, and what we call the deep medial cheek fat is actually two separate compartments. They are your deep medial and deep lateral cheek fat, and they are separated by the facial vein. Now you will see what some people call the split in the mid-face, your mid-cheek groove. This is the separation of those deep fat compartments. Don't inject into this mid-cheek groove because that's where your facial vein lives. What does the evidence tell us about these deep fat compartments and whether we can target them with our filler? Well, what the evidence tells us is that the souph, or the deep fat below the orbicularis muscle, is the most effective way to treat a mid-face. What they found within this publication is that the deep medial cheek fat here is the least effective. You almost have to use 3 times the amount of filler. So, for you as a doctor, if you just have 1 ml of filler, it goes in the souph. And we'll show you how to identify the SOOF very easily on the patient as we go through. So these are your deep fat compartments. Medial, lateral SOOF, deep lateral, deep medial cheek fat, your deep piriform space here, your mid-cheek groove. These are your superficial fat compartments. Nasolabial, median, infraorbital, middle and lateral cheek fat. They are your target. All of those are your target. Your median and the superior part of the middle are your key to a youthful appearance. So we're injecting our dermal fillers with those concepts of beauty in mind, but also we're targeting specific fat compartments from the evidence base. So what are we going to inject these fat compartments with? Hyaluronic acid. This is natural hyaluronic acid. It's long chain. It's a 3D structure. It's entangled. It's held together by covalent and non-covalent bonds. But there's a problem. It doesn't last very long. It maybe lasts for 1 or 2 days. So what do all filler companies do? They glue it together heavily with a chemical called BDDE. And this stops the degradation. But it introduces a new problem. And the new problem is rigidity or firmness of the gel. It's a very firm gel. And there's only one place for this gel, and it's deep. This is designed for static compartments. Remember, we age through each layer. So what can we place superficially without making our patient look strange? This is where the RHA fillers are really important for you, because they respect facial dynamic movement. They are FDA approved, the only product to be FDA approved for facial movement. And they look very close to natural hyaluronic acid. We've kept the natural bonds, and we've just added a low degree of modification. So not many BDDE, it allows the structure to move. And when you put these side by side, you can see traditional filler looks very different to these. So why do we need a gel which moves with the face? Why can't we just place any old filler, static filler here? Well, the face is not static. The face is highly mobile, and we have very, very different forces applied. So here, superficially, you place your gel in a superficial plane, you have an increase in shear and torsion. If you place your gel deep, you have more compression and stretch. How do we know this? Where does this information come from? Well, this is probably the most gold standard journal we have in aesthetic medicine. And the authors tell us that your gel is subject to very, very different forces throughout each tissue plane. And I'll show you an example of why this is important. Very important. What we have here is those classic 5 layers. And here we see the deep fat, here we see the muscular layer, and here we see the superficial fat, which is highly, highly dynamic. And when we smile, when we use those cheek elevators here, we can see a redistribution of the superficial fat. The volume doesn't increase. It just redistributes the fat. So we're going to give a deep injection here into the SOOF, which is static, with this time ultra deep. So this is a very firm, highly cohesive, high G prime filler, which is going to be injected deep. So we've got a classic perfect marriage of static filler in a static plane. So when the cadaver animates or smiles, we can see that there is no difference to the overlying cheek when the patient smiles. Now, here is using the same amount of product in the superficial. So now we have static filler in a dynamic area, and now you can see the problem. Your filler doesn't want to move. And that causes the problem. You've already seen this problem when you see these, almost this cat-like appearance to the eye, the smaller eye, the change on facial animation. And we have evidence for this mobility of the fat. And now we use ultrasound. It's great. We know that the superficial fat moves and the deep fat doesn't move. So now we have an opportunity to place static filler deep and dynamic filler superficial, making ourselves very, very sophisticated practitioners. So here the green is the superficial fat, and that's mobile. Here you can see the deep fat under ultrasound does not move. So, with our portfolio of dermal fillers, we can suddenly make a more evidence-based choice. We use RHA for the highly dynamic superficial fat, and we use the classic static firm gel for those areas which don't move. So we'll keep with the evidence. And this is a publication I really liked. I really like Sebastian Cotofana. He's a phenomenal anatomist, and he's contributed so much to aesthetic medicine. And what he's done here is looked at the anatomy behind this overfilled syndrome. And we've already seen these faces through that presentation when you see this type of appearance, that very strange alien type of appearance, especially in the mid-face. And there's a reason for this. This publication suggests that you as doctors need to sit your patient up and get them to animate and to smile with every 0.1. That's every 0.1 when you're using a static filler. This is to avoid looking overfilled. Why is this a problem? Well, you have a structure here. This is called the transverse facial septum. This runs from the lower part or the inferior part of the zygomaticus muscle to the periosteum. And when we smile, it contracts and it displaces the fat in a cranial position. So when you smile, your transverse facial septum will displace your fat. And here is a nice example of that. Here is my girlfriend, Cameron Diaz, and she's smiling. Her transverse facial septum has displaced the fat in a cranial position. Same lady, different problem. Can we see the problem now? We need to ask ourselves a question about Cameron Diaz. Maybe she doesn't have any money. Maybe she's gone to a practitioner who gives her things very cheap because she's poor. Doesn't have any money for the best fillers. I don't think so. Maybe she's got poor medical care in the US. Maybe they don't have good doctors. No. Probably the best medical care in the world. So we have a problem here. Cameron Diaz, an A-list celebrity, looks pretty strange. She now has 2 golf balls in her cheeks when she smiles. I don't think Cameron Diaz said to her doctor, "Hey doc, when I smile for the paparazzi, can you make me look really strange?" This is your classic problem of static filler in dynamic areas. You've already seen it on the cadaver. We need to consider the gel in the tissue plane. If you look really hard, the filtral columns, She didn't have filter columns, but these filter columns have a mind of their own. As she's trying to smile, they are displaced. So here they are moving to her left because it's static filler in highly dynamic areas. It doesn't work. Your layers here, bone to skin, separated by the SMAS or muscular layer into superficial and deep fat, your fat is very different. We know this now from the evidence. Your superficial fat is highly elastic. It stretches. It has to. Your face needs to move. That means we have to match the gel to the target area. It's okay in the deep fat. You can place whatever you wish. You can place concrete in there. It's not going to move. So we use our ultra deep here. Because those target layers are very, very different, we're beginning to catch up now with the evidence. And again, the evidence now is looking at dynamic facial rejuvenation. And this publication by Thierry Michaud was really interested because it really focused on each anatomical zone. So I've made this very easy for you. Reading the publication, it tells you the anatomical area, it tells you what forces are applied to the gel, and again, you can then apply your knowledge of rheology to each target zone. So it goes back to the beginning. And this beginning is understanding your aging, your anatomy, and your product choice. So basically ATP. So you have all of those tissue layers which age. You have static deep fat compartments which atrophy along with the bone. You place your highly cohesive, high G prime static gel here. This gives you the support and projection. Then we can volumize superficially in those areas which require superficial volumization. But this time we understand that the superficial fat is highly dynamic. So we use a different animal. We use RH84. This is just 4% crosslink, 60% crosslink less. So it allows the gel to move with the tissue. And this is important because it really gives us that natural appearance. And your patient's number one fear is not pain. It's not the price. It's the perception of them looking strange or unnatural. And this is how we avoid it, taking those concepts of beauty, understanding your anatomy, how you assess the patient, frontal, lateral, dynamic, and static, and then using the correct gel in the right tissue plane. So we'll stop there and we'll get to the specifics of the periorbital area. Do we have any questions at this moment in time? Everybody's really cool. Do you need more coffee? You can have some coffee in about 30 minutes, okay. Okay, so we're going to go a little bit more into the anatomy of the periorbital area now, because I know that's So periorbital, I'm going to put it into a bit of context with you. Most female patients are requesting periorbital treatments, whether it's with Teoxane or whether it's with fillers. So there is a large cohort or group of patients who want this treatment. And what we looked at here was that the number one indication from patients is tear trough. And that's interesting because one of the first things that I said to you today was, what is the first area to age? It's the periorbital. So patients begin to look at this. And what was interesting within this is that the tear trough is the second most treated area from a practitioner. It's actually moved away from the lips now, mid-cheek, tear trough, and lips. So why do patients really focus on their under eye area? This is why. This is how you look at each other. This is how you look at me. You look at each other like this, 2 eyes and a mouth. That's it. We are hardwired to look at each other like this. So there is no escape from the periorbital area, just like there's no escape from the lips. So this is why these 2 areas are incredibly important when we look at our patients, or more importantly, when the patient looks at themselves. So we'll go through this ATP, especially for the periorbital area, and you already know this. This is the cornerstone on which your practice is built. You already know the concept of layers. Now, I spoke to you about layers. Most of the face is made of layers of 5 separate components. Here, the tear trough, we only have 3. And it's a very small area. So from the medial canthus here, we have 3 layers. And those layers are skin, muscle, and bone. So the tear trough has an absence of subcutaneous fat. And that's part of your problem. The other problem is vascularity and very thin skin. And this is where the discoloration comes from. You get to the mid-pupillary line where the tear trough stops, and you go back to your classic 5 layers. Skin, superficial fat, muscle, deep fat, and bone. And your deep fat here would be that wonderful area called the SOOF, the suborbicularis oculi fat. So we have 2 very different configurations or arrangements of layers here. So your tear trough is a very small layer. So you will see this very often within the literature. You'll see the word deformity. And what the word deformity means in English is that something is anatomically not correct. It's away from the normal. Something is wrong. So, is the tear trough a deformity? Try telling this mum of this little baby that her baby is deformed. Okay. The tear trough is natural anatomy. It's natural geography of the face. And we'll look at what a tear trough is. A tear trough, very simply described, is the fixed ligamental position between 2 parts of your orbicularis muscle. The palpable or eyelid part of the muscle and the orbital part, the part which is outside of the bony orbit. It's just this separation between the 2. And here at the end of the tear trough, we have this area here called the pre-zygomatic space. This is in layer 4. So we're going to show you how to pinch and lift and to glide through this space. You may recognize this gentleman here. I've made Donald Trump a cadaver. You can thank me for it. Here we have a tear trough. The tear trough is yellow, 3 centimeters, fixed ligament between the palpable and orbital part of the muscle. The tear trough changes its name at the mid-pupillary line, orbital retaining ligament, and zygomaticus cutaneous ligament. So those are those fixed ligaments we can see on our patients. From a perspective here, you can see the tear trough then goes into the orbital retaining ligament, zygomaticus. The fat between these 2 here, superficially is your orbital fat, and deep is your SOOF. Here you can see the angular vein, which just sits below the tear trough, around about 2 to 4 millimeters. So that gives us a good indication of where the vascularity is. Using these, we can also identify fat compartments superficially. Medial to your tear trough is the nasolabial fat, and housed or stuck between the orbital and zygomaticus, here we have the infraorbital fat. The deep structures, or the deep fat compartments associated with these ligaments, is medial and lateral SUF, and collectively the deep medial cheek fat. So we can start to target very specifically our areas based around those fixed ligamental positions. Vascularity is an incredibly vascular area. We'll have the internal carotid artery here, we'll have the maxillary artery, and we'll have the external carotid. So it's highly vascular. And what we know here is we need to be incredibly careful when we are injecting here. This is the facial vein running through the facial groove, and it works its way up. You'll also have the facial and angular artery. We'll remove the skin here, and superficially, above the muscle, you can see the vascular network. So the vascular network here is above the orbicularis oculi muscle. And that tells you one thing. It tells you that you need to inject deep into the tear trough to avoid the vascular risk. Here is your tear trough. And then it extends into a nasojugal groove, which is the inferior part of your orbital part of your muscle. So this is where your facial artery will be. Your mid-cheek groove is your facial vein. This is the depth that we want you to inject with a cannula here, submuscular, through the SUF, below the muscle, avoiding any of those medial positions of those arteries here. Remember, these arteries can link to the internal carotid or the ophthalmic circulation, and there is a risk of necrosis of the forehead, but also blindness. The lateral part of your orbit here, you have to be incredibly important, because I know that some people like to give injections onto the zygoma with a needle. What we have to consider here is what is in and around those structures. So we have two foramina here. This is the zygomaticofacial. This is the infraorbital. This is your ligaments, and this is your SUF. So we have the supratrochlear, supraorbital arteries, zygomaticofacial, which is a cheek branch of the ophthalmic circulation, the infraorbital, angular vein, and angular artery. What's going to help you here is depth, understanding how deep these vessels are. You do not want to inject superficial. Here we can see that there's a duplex angular artery. So there is two arteries running in parallel. So that means two chances of vascular occlusion here. But these are above the muscle. So if you inject deep, you're going to avoid. Also, the path of the facial vein, angular vein here, is pretty predictable. Okay? It's just below your tear trough. And again, when it reaches the zygomaticus cutaneous ligament, it then just starts its path almost vertically down, superior to the infraorbital. So these little landmarks here give you a nice idea of where the facial vein is in relation to the infraorbital. So we can avoid this. My suggestion to you is always use a cannula. And use a cannula in the lateral part of the cheek. And we use one in the lateral part of the cheek for this reason. I like these patients. These patients don't have any foramina here, and I'll happily treat those with a needle. But look, here's 4 foramen, 3 here, and 4 here. And these are zygomatico-orbital, basically branches which go straight to the eye. So we have to consider when we're going into the SUF or into the infraorbital area here, is to use a cannula, a 25 gauge cannula. You do not want to be sticking a needle deep laterally to the orbit. We've had 2 cases of blindness from this artery in the UK. Although it's very small, you can still cause issues with this vessel. Ligaments are always interesting. And ligaments, you will hear different people saying, we're going to lift the ligaments with our dermal filler. Well, we've got to understand ligaments. This is a true ligament which goes from the bone to the skin. A false ligament goes from the SMAS or muscular layer directly to the skin. So how does a ligament age? Well, it doesn't age here where you'd like to put a bolus to push it up. Actually ages here. All of the changes are in the branches of the tree. So if I use my arm or my hand as a ligament, and this is the bone, we don't get any changes here. The changes occur here. So if you want to lift the ligaments, then you place the gel in the superficial plane to bring the branches back up. We don't have any significant changes of the ligament deep. The other thing about the periorbital area is we have very confusing terms and words. So the patient had a malar mound, or they had a festoon, or they had malar edema. What's the difference? What's the difference between these things? Because people will use these collectively. This is a festoon. This is not for tear trough, I repeat. This is not for tear trough treatment. This is a surgical. So what is the anatomical basis behind the festoon? Well, you say to your patient, dear patient, you need to go to see the surgeon because there is multiple issues here. The issues with a festoon is this. When we're young, we have an orbicularis oculi muscle, which is nice and tight. And as we age, it begins to lengthen. And as it begins to lengthen, then the fat will begin to prolapse through the muscle. And because we understand now group facial layers, this is attached to the skin. So as this begins to lengthen, then it pulls the skin together. You would combine that with the fact now that the orbicularis oculi muscle cannot work like it used to. We have a buildup of lymphatics. So your festoon is a lengthening of your orbicularis oculi, a prolapse of fat, and lymphatic compromise. This is why we can't treat it with fillers. It's surgical. A malar mound is just another name for infraorbital fat. And here you can see the very handsome Al Pacino had quite a prominent infraorbital mound, which is manifested as he ages into this. And this fat pad will get bigger as we age. This fat pad is very sensitive to water because the lateral lymphatics drain through this superficially into your parotid gland. So if your patient comes in and they have something like this, it's telling you straight away that there's a problem with lymphatics. Even with Teoxane or any type of filler, be very careful. So that, we've done festoon and we've done malar mound. Malar mound is just another word for infraorbital fat. Malar edema is something very different. We cause malar edema by placing filler. It's the #1 complication we have in aesthetic medicine. 11%. Remember, we said anatomically there's a problem with the tear trough. It's normal anatomy. It's discolored. There's no fat. It's very thin skin. But we get very greedy and we want to place lots of filler in there. And this is what happens. we get this. And this appears 5 to 7 days later. Your tear trough treatment was fantastic. And your patient comes in like this and says, hey, doc, what's this? Did you go on a sunbed, sauna, were you drinking alcohol? Or was it the fact that you as a doctor have placed too much filler, too superficially, or you've selected the wrong patient? Let's look at the anatomical basis. You already know now about the ligaments. Orbital retaining ligament, zygomatic cutaneous ligament, and here, between these ligaments, you will always see the malar edema. Just like you'll always see a hematoma stuck between the ligaments. It's a fixed. But here is the SOOF, and this is really the key. Understanding the SOOF, this deep fat compartment. This is just too superficial. This is what we see time and time and time again. This is the problem when you inject too superficial. We're going to have to break down the anatomy. This is your SOOF, your deep fat. And your SOOF is in a superior and inferior compartment separated by this structure, the malar septum. The malar septum is an impermeable barrier. Okay, this is why a hematoma will stay in that fixed position, because it's stuck between the ligaments. Nothing gets through. So, if we place our filler too superficial in the SOOF, it can only go one way. And it's trapped between the ligaments. And this is where you get your malar edema, by placing the gel too superficial in the SOOF. You may think you're deep, but you're not. This is why the prezygomatic space and a pinch and lift technique will help you. Also, when you're injecting into the SOOF, the deep fat of the midface, I use a needle onto the periosteum. I'm guaranteed to be below the malar septum. Malar edema doesn't come just from tear trough filler. It also comes from mid-face filler when you're too superficial. This is your problem, your lymphatics. You compromise the lymphatics. The lymphatics are avalvular. They don't have valves. So the lymphatic fluid can move backwards and forwards through. And again, its predominance is superficial. So this is why you inject deep. The lymphatic makeup of the eye here is that you have your medial channel, which is around about 30% of your drainage runs to your submandibular gland. Remember the infraorbital fat? Here you'll have 70% of your lymphatic drainage goes to the parotid gland. So this is why your SOOF and your infraorbital fat are critical to your outcome. Make sure you don't put too much in, and make sure you are deep to avoid the lymphatics. What happens if you get a malar edema? Well, hyaluronidase, and you're going to have to remove the work that you've done, or more importantly, what somebody else has done. And again, here I mark it out, and it's always between the ligaments. It's always in the same position. And what we do here is we always give hyaluronidase first. And if the hyaluronidase doesn't work, then we've got a problem. The problem is it's damaged lymphatics. So this is what we do. We use a high dose of hyaluronidase. Why? Well, we don't know normally what product's being used. Sometimes there's high volumes, high concentration. We only want to do this once. We give a firm massage and we review the patient in 2 weeks. There's no resolution. Short course of corticosteroids to help with the edema. If there's no resolution, it can take almost up to 12 months to resolve. So the key point here is don't overfill the tear trough. You're going to have a major problem. Underfill and revisit your patient in around about 2 to 4 weeks. I don't charge for the amount that I use in the tear trough. I charge for the visits, maybe 2 visits or 3 visits to get this right. Sometimes I have to do the mid-face as part of it. So I price the tear troughs very differently. Your assessment is key. So pressure test, look for edema, look for this infraorbital fat, which is sometimes waves at you, says, hi, I'm malar edema. Check the skin quality, just a snapback test. If something is longer than 2 to 3 seconds, they're normally a surgical candidate. Positive vectors we're going to look at, make sure that your patient has a positive vector. And again, ask the patient to look up, see if there is a tear trough, see if there is room to put volume in there and it's not discoloration. We discussed the positive and negative vectors. Positive vector is full cheeks, lots of volume, no lines, short tear trough. As we age, we have a negative vector, we have a deflation of the fat. So sometimes we have to replace the fat. And why do we do this? Well, this is what the evidence tells us. The evidence tells us that the severity of the tear trough is linked to how much volume we have in the mid-face. So if our patients have a deep tear trough, then we need to look at vectors. So this is a positive vector. You look at the most anterior part of the eye, you draw a line straight down, and you need or you want your cheek to be anterior. This is a positive vector. You've got a very short tear trough. You don't need any mid-face volumization. You can just treat the tear trough as a standalone approach. A neutral vector is where the eye and the cheek are in line. So this requires mild anterior projection followed by direct tear trough treatment. Your older patients or patients with a retruded or posterior maxillary position have a negative vector. You can see that the cheek is behind the line, the tear trough is now very long, the lid-cheek junction. You require mid-face volumization first, followed by tear trough treatment. So how are you going to do this if someone has a negative vector? You know this. You go to the SOOF. You go deep in the SOOF to the periosteum. It's the #1 target for our filler. We avoid the malar edema by injecting deep. It gives us almost a 95% projection. Why do we want to create a vector? We want to shorten the lid-cheek junction. Again, you've already seen this. This is really important. Mid-face volume is linked to tear trough. Your techniques, everything has to be injected deep. So that's the word of today for the tear trough, deep. You can use a needle or a cannula here. It's completely up to you. There are 2 ways to do this. A needle, you can just go along the bone deep, or a cannula, which is my preferred, is a single entry point, 25 gauge, not a 27. We're going to move into the tear trough below the muscle here, and this is the lower risk way to do it. We're going to access it through the prezygomatic space. So this is below layer 3, this is in layer 4. The spaces of your face are in layer 4, in around the deep fat. We're going to go below the muscle and we're going to glide our cannula all the way anterior here, through the SOOF, below the muscle, into the tear trough. Here you can see the absence of fat quite nicely into the tear trough. So this SOOF is our target to slide our cannula through and move to that position. This is the pinch and lift technique. This is what we're going to do. We're going to glide underneath in that space towards here. You can access the tear trough through the premaxillary space, but it's pretty painful. Some of you may have seen on Instagram a doctor going intraoral to the tear trough. If you haven't seen it, ooh, yeah, it's not very sterile. You've seen it, madam? Yeah, it's not. Yeah, it's terrible. Yeah. So I don't know why people are doing these things, but it's a bit strange. But I suppose it's a show for Instagram. Okay, so we're going to put all our knowledge and information together. And what we're going to do now, we're going to watch a short video on me treating a tear trough, looking at the anatomy on our patients. Here's your technical challenge: no fat, thin skin, vascularity, and a dark muscle. So that's your challenge straight away. Here's the anatomy. Here's your tear trough, orbital retaining ligament, and zygomaticus cutaneous ligament here. We know that the facial vein will sit below the ligament, and the angular artery is more medial to this. So we have in our head a three-dimensional idea of what we're going to access. We're going to use a 25 gauge cannula, and we're going to go through the prezygomatic space. We're also going to treat on this lady the palpable malar groove. Again, remember, keep into consideration the zygomaticofacial and zygomatico-orbital. We're going to use some Redensity 2, which is the first product licensed and the first with an indication for tear trough. It's incredibly light, and it is, we're going to talk about the word hygroscopic in a bit. Okay, so this is the 23 gauge entry. We're going to be very flat to the skin. You can see here, I always mark the patients with a little white marker, because when the patient lays back, you lose your reference points very easily. So we pre-mark the patient, and what we're going to do here is just glide our cannula up. I'm going to be very mean, and I'm going to show you what too superficial is. So this is too superficial, okay? What you want to do is a pinch and lift. So we're going to go down, touch the periosteum, and then slide. If your cannula doesn't slide, you're in the muscle. So if it's stopping like this, you're intramuscular. Reposition, lift, pull, and go deeper. This is where the Redensity 2 is going to be, submuscular here. We're going to slide forward. Now remember, you will come more superficial here because there is no tissue. And also, your zygoma will push the cannula in a superficial position. Our recommendation is not using more than 0.5 per eye. And there is a reason for this, and that is really to avoid that malar edema. From the same entry point here, you can turn your cannula around and you can access the palpable malar groove, again, which in the aging patient, due to the changes of orbit and reposition of the fat, is really a nice way to rejuvenate the eye and to create that element of youthfulness. So you will feel that little pop here, and that's the ligament. Okay, so you have that idea of where you are. So I'm just above the bone here, just underneath that thin skin, and I'm just depositing a couple of little drops of Redensity 2 in this area, creating another little thread, and then we massage. Massage is incredibly important because we don't do enough of this. Massage from lateral to medial, okay? So don't go back from medial to lateral. You'll just pull the filler out of the tear trough. So that's your tear trough treatment. And that was the before and after. I've done a mid-face, I've done a temple, lateral eyebrow as well. And you can see that there is a nice rejuvenation in that periorbital area. Your product selection is always Redensity 2. Anything else, you're just asking for trouble. Okay? And you'll end up putting hyaluronidase. There is lots and lots of evidence available now on Redensity 2 and its importance in treating the infraorbital area. Why? Well, because it has all of these properties, and these are the ideal properties for a filler in the eye. And this one is probably one of the most important, because we know the lymphatics are very delicate here. Hygroscopy doesn't mean just the attraction of water. It means the holding on to the water. So this is a very, very low hygroscopy. And it's indicated for the tear troughs to be injected deep, submuscular here, mixed of cross-linked and uncross-linked, just a low degree of hyaluronic acid here. If you look at it against one of the classics here, you'll see that it doesn't exert a lot of pressure on the tissue. If it doesn't exert a lot of pressure on the tissue, it doesn't exert a lot of pressure on the lymphatics. So that is perfect for the under eye area. Again, we're going to control the risk of edema because that's a huge problem. Looking at the competitors here, this is Volbella, Stellage and Bellatero. We're looking at hygroscopy, so the ability to hold on to water, really low. How firm the gel is, you do not want a firm gel under the eye. Red density 2, very, very soft, and it spreads beautifully. So you combine all of those factors here, you have a gel which is very, very safe and efficient. It's the optimal gel here, and it reduces that risk of edema. Remember, it's that #1 complication we have in aesthetic medicine. So, low hygroscopy, light consistency here. We're going to inject deep onto the bone, slow injections, small volumes, choosing the right patient. We're going to inject deep, as always, in the infraorbital. You're going to identify the patient, and if they have a negative vector or a neutral vector, then you may need to use a volumizer deep in those areas. Again, everything is in that area which you are going to avoid all of the lymphatics, which is deep. So remember the Teoxane approach: anatomy, assessment, aging, your technique, and your product choice. And remember that the face is both static and dynamic. Thank you. I'm 10 minutes over. I do apologize. Okay. Is it coffee now? Yeah. Okay, let's have a coffee. Okay, let's get our brain cells back working. And how long do we have for the break? 15 minutes? Yeah, 15 minutes. 15 minutes, okay. Perfect.
Throughout the ages, the concept of ideal beauty has undergone changes, and the aim of eternal beauty has remained elusive. Legends and myths are filled with stories of metaphysical transformation and attainment of youth. It was not until the early 20th century that the first hyaluronic acid, or HA filler, was isolated, and several decades later, it revolutionized the field of cosmetic procedures forever. Dermal fillers have evolved from collagen, which elicited immune reactions and are designed to closely resemble HA, a natural substance in the skin. They are developed in a cross-linking process using non-animal products to create a gel that maintains the structure and composition of natural HA. Dermal HA fillers are implanted through injection at different layers of the skin. Once injected, the gel stays at that layer of the tissue and is slowly broken down by an enzyme called hyaluronidase. For most dermal fillers, this process may take between 6 to 12 months. But not all HA fillers are made the same, with composition and characteristics of a filler deriving directly from the process by which it is created. Initially evolved to reduce wrinkles and folds at rest, and later to provide volume and address static expression, it is now dynamics that represents the fourth dimension of facial aesthetic. Preserving facial dynamics is a necessary quality in a filler and is essential to achieving natural-looking outcomes. The notion of natural-looking beauty was of utmost importance to Madame Valérie Taupin. She was the co-creator of Juvederm, and she set her mind to making a product that was natural-looking, long-lasting, and safe. This is when Madame Valérie Taupin, along with her experienced clinical team, first envisioned and then went on to create resilient hyaluronic acid, RHA. The exclusive preserved network technology uses a gentle manufacturing process to maintain longer HA chains and their low-energy bonds to more closely resemble natural facial HA. This proprietary manufacturing process minimizes the amount of BDDE required and allows the RHA structure to remain resilient and adapt well to the skin's movements. What makes RHA different? In a word, resilience. Resilience means the ability to spring back into shape after repeated stretching, bending, and being compressed. High stretch and strength of the RHA collection make it resilient, helping it adapt to facial movement and tissue constraints. Stretch is the ability to deform without breaking. It represents the malleability of a filler, the ability of the gel to adapt to dynamic facial movement. Strength is a measure of the ability to maintain physical integrity and viscoelastic properties over a wide range of stress and deformations. These advanced properties make RHA the first and only HA fillers designed for dynamics, the fourth dimension of facial aesthetic. Launched in 2015, the RHA collection is approved in 79 countries, now including the US. FDA approved for dynamic wrinkles and folds, the RHA collection gives patients natural-looking outcomes. The RHA collection is resilient by design and made for facial dynamics to move with each and every expression. Each filler in the RHA collection has its unique combination of high stretch and strength and is made to serve distinct patient anatomies and aesthetic needs. The RHA collection, exclusively from Revance, represents a breakthrough in aesthetic technology and will only be available to an exclusive set of US injectors who focus on providing a premium experience to patients. While beauty is timeless, the time has come for a new way to maintain it. The time has come for RHA. Throughout the ages, the concept of ideal beauty has undergone changes, and the aim of eternal beauty has remained elusive. Legends and myths are filled with stories of metaphysical transformation and attainment of youth. It was not until the early 20th century that the first hyaluronic acid, or HA filler, was isolated, and several decades later, it revolutionized the field of cosmetic procedures forever. Dermal fillers have evolved from collagen, which elicited immune reactions and are designed to closely resemble HA, a natural substance in the skin. They are developed in a cross-linking process using non-animal products to create a gel that maintains the structure and composition of natural HA. Dermal HA fillers are implanted through injection at different layers of the skin. Once injected, the gel stays at that layer of the tissue and is slowly broken down by an enzyme called hyaluronidase. For most dermal fillers, this process may take between 6 to 12 months. But not all HA fillers are made the same, with composition and characteristics of a filler deriving directly from the process by which it is created. Initially evolved to reduce wrinkles and folds at rest, and later to provide volume and address static expression, it is now dynamics that represents the fourth dimension of facial aesthetic. Preserving facial dynamics is a necessary quality in a filler and is essential to achieving natural-looking outcomes. The notion of natural-looking beauty was of utmost importance to Madame Valérie Taupin. She was the co-creator of Juvederm, and she set her mind to making a product that was natural-looking, long-lasting, and safe. This is when Madame Valérie Taupin, along with her experienced clinical team, first envisioned and then went on to create resilient hyaluronic acid, RHA. The exclusive preserved network technology uses a gentle manufacturing process to maintain longer HA chains and their low-energy bonds to more closely resemble natural facial HA. This proprietary manufacturing process minimizes the amount of BDDE required and allows the RHA structure to remain resilient and adapt well to the skin's movements. What makes RHA different? In a word, resilience. Resilience means the ability to spring back into shape after repeated stretching, bending, and being compressed. High stretch and strength of the RHA collection make it resilient, helping it adapt to facial movement and tissue constraints. Stretch is the ability to deform without breaking. It represents the malleability of a filler, the ability of the gel to adapt to dynamic facial movement. Strength is a measure of the ability to maintain physical integrity and viscoelastic properties over a wide range of stress and deformations. These advanced properties make RHA the first and only HA fillers designed for dynamics, the fourth dimension of facial aesthetic. Launched in 2015, the RHA collection is approved in 79 countries, now including the US. FDA approved for dynamic wrinkles and folds, the RHA collection gives patients natural-looking outcomes. The RHA collection is resilient by design and made for facial dynamics to move with each and every expression. Each filler in the RHA collection has its unique combination of high stretch and strength and is made to serve distinct patient anatomies and aesthetic needs. The RHA collection, exclusively from Revance, represents a breakthrough in aesthetic technology and will only be available to an exclusive set of US injectors who focus on providing a premium experience to patients. While beauty is timeless, the time has come for a new way to maintain it. The time has come for RHA.
Can everybody hear me at the back? Yeah, perfect. Okay. So we have our beautiful patient here, Milana. Okay. She's had a bit of previous treatment into the mid-face, and what we're going to do is we're going to close in just until we have a full face, and we're going to look at the facial assessment. So if Milana just looks at the camera straight ahead here, then we're looking at the facial shape, and she's got quite a nice facial shape. We look at the bitemporal width, the bizygomatic, and the gonial. The gonial is slightly increased into this position. So if we were to reduce this, you would see more of a thinner type of face and a less accentuation of the lateral cheekbone. Now, she's had her cheekbones treated previously about a year ago. And if we just rotate her just to the side, you can see that the volume here is mainly in that lateral aspect. And one of the things that we discussed today as a group is that over accentuation here of the lateral part of the cheek is more of the male type of appearance. What we'd like on our female patients is more anterior volume. So if we just bring her just slightly to the front, and if we increase a little bit of the medial volume here, we can see this facial shape begin to change. So my goal here is just to restore a little bit into the medial soothe, not lateralizing. The reason why we don't want to go lateral here is a couple of reasons. One is that she's already fairly full. We don't want to create any more volume here because it does two things. Number one, it makes the temple appear deep. So we can age our patients very quickly by injecting too lateral. The other thing it does, and some patients quite like this and others don't, is it creates this shadow here in the preauricular area. And again, this can be looked at as being sort of an increase in volume loss. And in some patients, it's undesirable. So injecting too much lateral here can have a knock-on effect onto the temple and to the preauricular area. When we look, and we're going to show you on our next patient, when we look at the periorbital area, and again, this is one of the concerns we have with our patients, is they tend to look at their eye. She's got a beautiful eye, but in the lower part here, you can see there is a definite tear trough. And what we want to do with this is just create a little bit more light onto here and onto this palpable malar groove. If we ask our patient to bring their head forward, you can see a little bit better now. And if she looks towards the sky, you can see that two things happening here. One is you can see the volume shift, but also you can see this degree of pigmentation. And I know as a lot of you dermatologists here, you can have your own ideas how to work on this little area of pigmentation. Again, this can be very accentuated in patients who have hay fever and they rub their eyes a lot, a little bit of post-inflammatory hyperpigmentation. You can also see with creating too much volume lateral here, you can create almost a palpable malar groove into this area by just over-volumizing this aspect. Again, the tear trough and the palpable malar groove are really a key feature in the aging process. How do we assess our patients? Well, again, we have those ideas of pressure where we push and we see if there's any permanent edema into there, which is going to cause us a problem. The other is the skin quality issues where we pull and release, and again, quite good skin quality. We're going to ask our patient to look up, again, for volume. We've got a little bit of volume depletion here medially, and if we keep turning, you can see that she's quite flat into this anterior part of the mid-face. And she's got a neutral vector, so I want to just increase this before I treat the tear trough directly. What we're going to do is ask Gary to just clean this side. Is we're going to look at some of the vascular components to this side, and we'll really build our treatment on one side and treat this area. So we had some very specific areas. So this is the tear trough, a very short anatomical ligament. It stops at the midpupillary line. It will then go into a multilaminar orbicularis, and we can start to pick out these areas here. This is the infraorbital fat, and below this would be the SOOF. In relation to these ligaments here, we'll have a small vessel around about this lateral part here, emanating from the lateral SOOF. This is our zygomaticofacial. We draw a line vertically down, and medial to this, we have the infraorbital. We also know from the infraorbital, in position related to these ligaments, is that you can see, again with the eye of faith here, on most of your patients. Can we have another blue? If not, we can do it in white, it's no problem. You can see quite clearly here, you can see this blue vein, the angular vein, which will drain from the forehead, from the central and paracentral veins, into the facial vein, all the way down into the neck. But I'll do this in white, okay? So this would be the angular, and it will go round the back of the infraorbital, hits the zygomatic, and then works its way to the anterior border of the masseter. So this is that mid-cheek groove that we don't want to inject into. Thank you so much. So we got, just from this, we have some very unique anatomical landmarks that we're keen to avoid. Again, medial to your vein here, which I will just go over in blue just to give you a better idea, is your angular. Okay, again, this vessel here can be incredibly variable. Between your facial vein and facial artery, you'll have your nasolabial fat. So we started to pick out some really, really nice anatomy, again, from midpupillary line to lateral canthus. This is our medial SOOF. Our medial SOOF is the most receptive fat compartment. Our lateral SOOF here, again, is a target. And then below is our deep lateral and deep medial cheek fat, either side of that facial vein. So we've got lots of anatomy here, which can be made very, very simple by understanding the depth. All injections here into the periorbital and the midface are going to be deep, deep into the SOOF. We're not going to accentuate anything at the lateral because she's already full. So I don't want to make this looking any more projected because I'm going to deepen the temple. The other thing that I'm going to do with our patient is I'm going to increase the volume of her lateral eyebrow. This is one of the key features on all of your patients, and I think it's an area which is very, very undertreated. As women age, what they tend to do is they tend to draw their eyebrow longer with a pencil, okay, to give the illusion. We lose volume here in the temple, and I'll show you how I inject temples on the next patient, to just lengthen the eyebrow, to just give it a little bit of projection here. So my goal here on our patient, the treatment plan, is I'm going to inject the medial SOOF with some RHA4 just to give a projection into the anterior midface to support the lid-cheek junction and move Milena from a neutral vector to a positive vector. Once I've created a positive vector here, you can see how flat she is in this area. Once I've corrected the vector, I'm then going to use Redensity 2, so that very low hygroscopic, very smooth, very low pressure on the lymphatics. And I'm going to create a bit more projection and light into the tear trough. And then I'm going to treat a little bit onto the palpable malar groove just to disguise. With this, I always have some Redentity 2 left over. Then what I'm going to do here is reinflate the roof, the retroorbicularis fat of the lateral eyebrow to give the illusion of a longer eyebrow, which is a more youthful and more feminine appearance. My typical volumes in the mid-face would tend to be, with the SOOF, that most receptive fat compartment, is around about 0.3 to 0.4. My volumes in the tear troughs are quite low, 0.1 to 0.2 and maybe 0.1. That would leave me quite a lot of filler to do the lateral eyebrow. How many people are doing lateral eyebrows on patients? There's a halving sometimes. Yeah, so I think it's really important is that you start to look, and again, our next patient, Eva, you'll see that she has a classical sort of folding in of the temple. Remember, the temple, lateral eyebrow are linked to periorbital. Don't be fooled to think the periorbital is just the tear trough. It's not. It's an area, it's a complex full area. This is the number one area that patients request. So what we're going to do is that we're going to mark out the tear trough, the palpable malar groove, and the areas we're going to inject. We'll just keep those on for a second, Gara, okay, before we inject. So remember, when our patient lays back, we tend to lose the reference points. So what I do is I always mark the areas I'm going to inject, because under the lights, we can see that the white mark lives pretty nicely. So just look up for us. And again, the tear trough is going to go from that medial canthus, and it's going to stop at the mid-pupillary line. So again, I'm just going to put that volume into here. My last area which I'm going to inject into is I'm going to go from the lateral zygoma to the peak of the brow here. And what I'm going to do is I'm going to fill this lateral brow just to give a little bit of a raise onto this area. Okay. And again, I'm going to use the Redentity 2 for that. You okay? Okay. Does anybody have any questions at this moment in time? Yes, you can clean. Nobody has any questions? Obviously, you're too shy, or I'm too good. I think you're just too shy. All right, so first things first. We're going to have mid-face volumization with the RHA4, just with a needle. Now, you can do this with a cannula, but you can end up placing the gel superficially, and we know about malar edema. It's when the gel is too superficial into that medial SOOF. I'm going to use a needle, and then lots of people say, oh, where's the infraorbital? It looks like you're pretty close. There's a really easy way, a very easy way, thank you, to identify the infraorbital foramen. Okay, if you like numbers, like most people do, it's 26 millimeters from the lateral orbital rim towards the midline and 10 millimeters down. If you haven't got the capacity to measure, you just draw a straight line from the mid-pupillary line. Very simply like this. Your infraorbital artery will always, 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 always be medial to this line. So, if you inject laterally to the line, you're not going to inject into the infraorbital foramen. Okay? Very simple. And again, this is evidence-based, this is anatomical-based. So we're going to stay lateral to the mid-pupillary line. Again, your facial vein will run through the deep fat and then become more superficial as it reaches the angular area here. So again, a deep injection onto the periosteum, into that medial SOOF, lateral to the midline, is your real key to two things. One is efficiency, and two is safety. So, mid-pupillary line, okay, we have the mid-pupillary line here to the lateral canthus on the bone. This is the SOOF. So what we're going to do to the SOOF is we're going to inject deep onto the periosteum. Just gently touch the periosteum. You okay? Mm-hmm. Any pain? No pain? Okay, good. And we're going to watch the skin, and we're going to inject very, very slow, and we're going to keep the tip of the needle moving, so we're not going to fill any artery that we could be in with a bolus of filler. So we're just going to keep the tip of the needle moving as we inject. So you can do this with a cannula, but you can see the reasons why I'm injecting deep here is because of the malar edema. I really don't want to inject anything superficial here, which is going to cause me a major problem. So you don't have to keep contact with the bone and press on the periosteum, because it can be a little bit painful. My suggestions to you would be to inject very slow, keep the tip moving, and ask your patient for feedback. So we can see a nice projection already. Here, that medial part of the cheek, so the most feminine part of the cheek. Remember, we have a 2-to-1 relationship between the fat of the mid-face and the fat of the lateral face. So here we're going to put 0.4 of deep periosteal injection with RHA4 to support the lower lid, but also to create a positive vector. So, get up. Thank you. So we'll sit our patient up. Okay. Okay, and we can start to see the changes we've made. You can actually see the difference it's made already onto the tear trough area. Here's my big tip for you in practice. Always take before photos. Always take after photos. But my biggest tip is do a during or in between. Always get a picture like this, because when you do both tear troughs together, your patient looks in the mirror and says, I don't think there's much difference. When you do one, they go, oh my God, the difference. Take your picture hemi-face and then full face. Okay. So here you can see the changes that we've made on this with just a small amount of filler with a targeted approach. The next, once we've corrected any mid-face volume, is we're going to treat that palpable area, and we're also going to treat the tear trough. And we're going to do this with Redensity 2 on a cannula. Now this, you can use different cannulas, different lengths. You can use a 38 millimeter, you can use a 50 millimeter, but my suggestion would be to use a 25 gauge. This is the lowest risk that we have. Patients at this stage, they always want to close their eyes, okay? They don't like the fact that you're doing tear trough treatment in and around the infraorbital area. It's important for your patient to keep their eyes open. It shows you the amount of volume that you need to place into this area. So what we'll ask our patient to do is to keep her eyes nice and wide. Now, a couple of things here with your entry. Needle, and if our cameraman comes nice and close, you can see the opening of the bevel is facing out. This is the sharpest part of the needle. We often see people do this or this. This is the least sharp. So make sure that your entry point is up. And also make sure your entry point is here on the flat of the cheek. I'm going to show you why you don't want to inject from too far lateral here. If you watch the tip of the cannula, if I'm injecting from here, look at the tip, it gets pushed superficial. And if I'm superficial here, then I'm going to be really superficial. So my entry point is going to be here on the flat of the cheek, so I can keep my cannula really nice and flat on the plane and I can access both without the cannula being pushed forward. This is a really nice cannula. This is a little 40 millimeter, 38 millimeter cannula, 25 gauge. And really this is a nice, it's not too flexible. So we're going to find a little entry point here. So we're going to stretch the skin and we're going to make a little scratch. If you're going to get a hematoma, it's likely to be here, just on that apex of the cheek where it's really vascular in terms of superficial vessels. And I'm going to work my way forward into this area. So again, with this, I'm going to show you what superficial is. We're going to do that pinch and lift, where we're going to lift up the tissue really high. We're going to change the angle of the cannula, and we're going to go deep. And then we're going to slide forward. Can you see how easy the cannula is sliding? No pressure to the cannula. The reason why we have no pressure to the cannula here is because we're sliding below the muscle. And when we slide below the muscle, there is hardly any resistance. Because we're in that prezygomatic space, gliding deep through the SUF, it's very easy. So if you meet resistance in the infraorbital area with your tear trough, you are likely to be inside the muscle. And that could be problematic. So we're just putting very, very small aliquots going from anterior, little anterior grade injections, working our way forward into the tear trough. And then we're going to change direction. And you can make another entry point here if you wish. And then we're going to work towards the palpable malar groove. Now remember, when we get to the ligament here, we will feel some resistance. Okay. Now the tip of my cannula is just here, just towards that lateral canthal ligament. And what I want to do here is just deposit, and you can see the cannula just at the ligament here. I'm going to create a little bit of volume just into here. So far I want to use 0.2, so very, very small amounts of filler into this area. Again, little anterior grade threads on the way back. Keeping your tip of that cannula moving at all times. The palpable malar groove is such an important area as well, because that lateral orbit ages, so we'll age in this direction from inferior medial, so the orbit will open in this direction. We're going to massage in, never away, because you're just going to pull the filler out of that area, okay? So we've got a palpable malar groove now, which has now got a smoother transition. You can see the tear trough palpable malar groove here. And again now, we've got a nice correction to that tear trough area. We're going to come and sit you up. Okay. And you can see there is the start of some really nice changes to this part of the face. Actually looks a lot more rejuvenated. So I've used here on the palpable malar groove and the tear trough just 0.2. Now I've got some filler left, and you'll always have filler left. Never discount your patients, always add value. And the added value here is to create volume in this lateral eyebrow. So I'm going to show you how I do the lateral eyebrow at this position. Can we see those changes? Do those changes look okay? So there's the palpable malar groove, tear trough and neutral vector. Keep turning. Okay. We've got positive vector now. Improvement in the palpable malar and in the tear trough. I'm just going to ask you to look straight ahead. Okay, you can see the changes here. especially in the palpebral malar area, you've got a smoother transition. So we're going to do the lateral eyebrow now. Now you can do this from a couple of ways. You can inject deep here with a needle and run it along, but again, it's likely for hematoma. I'm going to make a small entry point here and work just underneath the brow. I'm going to lift the brow in this position, and I'm just going to fill and re-inflate this area, and I want to see on our patient that we have a longer brow. Okay. We're going to ask our patient to lay back. Can we have some wet gauze? Thanks. Perfect. Okay, and we're going to turn you this way. You can just stay, I'll work around you, okay? So again, you can do the temple and the lateral eyebrow at the same time. But we're going to do the temple and lateral brow on either now. So again, the same principles here. We're going to keep the needle facing up. We're going to stretch and press the skin. Very shallow entry point. You don't need to spin or twist. This is just an entry point to get you through that area. And then we're going to work our way forward again into that fat of the eyebrow. And we're going to work our way forward. So again, if you're in the right tissue plane here, the cannula should move really freely. And you can see very nicely here that we're now just under the peak of the brow. Again, this will look superficial to you, but we're just above the periosteum here, and you can see the tip. So what I'm going to do, I'm going to lift up the brow, and I'm going to fill the eyebrow. And what I want to see is a little increase in light reflectivity here. Again, with the longer cannula here, you can go and do more to that medial aspect. So what we're doing here is slight projection of the eyebrow, but we want to give that illusion of having a longer brow. And again, typical amounts here will be around about 0.2 to 0.3. Not a great amount. Again, females will tend to put light makeup in this area, like white highlighter, to accentuate the light. You can do this with fillers very easily. So here we've used just 0.25 in that lateral brow. Again, a little bit of massage here. Remember, we always like to massage. I don't like to tell the patients to massage because they don't know how to massage. Okay, can we just zoom out, please? And can we come a little bit more? So we're going to turn you this way so you can see. So we've elevated the brow, we've projected and lifted this area, given a more youthful appearance. One side of the face looks short, the other side now looks longer. We're going to should we show our patient in the mirror? Do we have a mirror? The power of the eyebrow is incredibly important. You know as women how powerful this is. So this is the side now, which is your good side. Yeah. Okay. Nice change. Okay. All right. So I think I've still got a little bit of volume I can place in here. One of the things you need to do with the patient is get them to sit up regular and really take a little bit of time to reassess what you've done. Again, to pop yourself back. Hopefully, this little entry point will still be open, so we don't need to do two. Again, I will try to do this with this pinch and lift. So pinch up the skin, almost going vertically down, and then we're working our way forward. Okay? It should be really nice and smooth. And again, just small amounts into that area which you've marked, which is the little depression just below that bit of hyperpigmentation. And really, you shouldn't be putting huge amounts of product into this area because it's just going to cause you big problems. Okay? So now that looks corrected to me. So we want to get a one-to-one correction because you're not going to get much water which is going to swell into this area. Did we have any questions so far? No questions. Everybody's super quiet. Sylvia with the red hair, you're very quiet because I know you. Yeah. Yeah. You're not normally quiet. Yes, madam.
Why do you don't aspirate?
Okay. We're going to have the question now. Okay. So my first thing to say is that if you aspirate, continue to aspirate. Okay. I'm never telling anyone not to aspirate. I'm very much driven by the science, and the science tells us that aspiration is not reliable. So it's not a reliable thing for me. Also, aspiration is, if you move the tip of the needle, your aspiration is cancelled. So aspiration is only for a static injection. As soon as you move, I see people aspirate in the lip and then do this. What's the point? Yeah. Makes no sense. So we have to look at the evidence, and the evidence tells me it's very unreliable. It's less than 30% reliability. Now the evidence is telling me to fill the needle each time with saline before I inject, because that makes it easier to aspirate. I just can't do that practically with the patient. Where I'm aspirating and where I'm injecting are in two different positions. So for me, aspiration is unreliable. What do I do with the patient to try to negate that? Well, one, I try to understand three-dimensional anatomy, looking at depth. Secondly, pain is your biggest indicator. Don't be fooled by saying that it's not painful. It's painful. Patients don't report the pain. Doesn't mean the pain doesn't exist. Every single case of blindness, vascular occlusion, has had a negative aspiration. So that tells you everything. It's not reliable. Pain, is it painful? Does it feel painful in your nose, your forehead, in your teeth, in your chin, anywhere distant? Is the pain increasing? The patient tells you straight away. We also look at the skin. We use targeted digital pressure, and I'll show you what that is in a second. When we do the temple, we close the artery with our thumb or our fingers, and then we inject. We make the vessel as small as possible. We're in the right tissue plane. We use a cannula. A cannula risk is 1 in 40,000. 77% less risk than a needle. So we use the right instrument. I can't rely on doing this for my safety. That's just me. That's like the equivalent of wearing a seatbelt and driving at 300 kilometers an hour, saying, the seatbelt's going to save me. No, you're still going to have a big accident. Okay, but keep aspirating, but do other things as well. Okay, I knew someone was going to ask me the question. All right. I know time's getting on, so I want to show you how I do the temple. I think that's really important because this case is a classic case on the facial assessment that we've just looked at. So we'll change patients over, and we'll treat our next patient, Eva. Can we change over? And I'll finish the treatment off camera while you have your lunch. Eva. Okay. So you as a group now are going to tell me about facial shape. Okay? So if our cameraman stays central, I'll work around the camera. Okay? So you can stay in one position. All right? I'll work around you. I'll make your job easy. Okay? One of the things about facial shape here is we can begin to make our patient look very masculine. We can also make our patient look older as well. And what we have with Eva, who's 26, she will be 26 in a second. She's 46. Has the first thing which we're looking at, and again, we're going to sit Eva forward. All right, so you're going to do the assessment on facial shape here. Okay. So what facial shape do you think Eva has? Heart-shaped, oval, square? Yeah. Who said square? Good. You get a bonus point. Okay. Yeah, she's starting to become square. Now, we looked at, early on in the session, bitemporal, bizygomatic, and bigonial width. So we looked at bitemporal width, we looked at bizygomatic width, and we looked at bigonial. Is this a female proportions, or is it more of a masculine? Okay, it's more masculine, isn't it? Okay, because of the increase in the gonial width here, which will only increase as we get older. So this will continue with soft tissue to become wider. Now, the thing with my beautiful Eva here is she's got an amazing jawline. And if you add volume to this, it's just going to increase this. So you're going to make this square. What is your eyes drawn to? What are you looking at thinking, I want to treat this? Speak to me. Temple. You're looking at the temple thinking, that needs to be treated. The temple hollowing. Look at the eyebrow. The eyebrow has fallen into the temple. There's the brow. There's the end of the brow. Look at this. It disappears. So again, this is why our patients draw their eyebrow longer and longer and longer, because they lose volume in the temple. The temple is part of the periorbital area. You lose volume in the temple, you skeletalize the periorbital area. Again, she's got amazing volume here, but again, for me, there's too much projection laterally. And that's accentuating or making worse this, making this look deeper, because this is now wider. Again, causing this submalar hollow. But she's also got masseter hypertrophy. She's clenching and grinding her teeth. So treatment planning here would also need neurotoxins into this to create this. And her facial shape looks so much better by a reduction of millimeters in the lower face, because we understand that the male has a wide gonial width. So we're not going to add any volume to the lower face. In fact, this is the area which is depleted. So, how does the temple age? How, or what is a temple? I'm going to ask Eva to pop her head back. And we're going to turn her this way. Okay. So what is a temple, or what is a temporal fossa? Well, it's a huge area. It's about the size of my hand here. It's home to the temporalis muscle, a muscle of mastication. But in terms of what we treat from an aesthetic point of view, we can see here the temporal crest, the lateral orbital thickening, the upper part of the zygoma, and the hairline. So in terms of an anatomical unit, it's relatively small. How many people do a deep injection here? Who does a gunshot? Put your hands up just so I can have a flavor. Sylvia, you changed now. Yeah. Okay. How many people are injecting superficial? Me. Okay, just me. How many people are treating the temple? How many people are not treating the temple? Oh, there's a couple of you. Okay. So we've got people injecting deep, people injecting superficial, people who don't want to tell me what they're doing, okay? And we've got people who don't treat the temple at all. So what is the anatomy of the temple? Well, there's 10 layers going from the skin all the way down to the bone. And how does the temple age? Well, the temple ages not through the bone. We have no bony changes in the temple. So we're not trying to replace bone here. We have just two areas in the temple which age, and that's the fat and the muscle. So we get an absence of the fat, and we get an atrophy of the muscle. So we can easily treat the fat. Now you'll have different fat compartments here. You'll have the superficial fat, you'll have the intermediate fat, and we'll have the deep fat. The deep fat is the buccal fat of the mid-face. And that's an area which you don't want to fill because you're going to end up with a little bit of migration down into the mid-face. So your target here is superficial fat. Now most of you are thinking, oh no, I'd never inject superficial. It looks like there's lots of veins, arteries, and I'm going to see the product. Well, if you inject deep, you have 10 layers to push forward before you get a result. If you inject just below the skin, you'll get a big lift. So you're using typically in the muscle deep volumizing fillers. I'm going to use RHA1, which is the lightest filler we have, and I'm going to go just below the skin. This is what we used to do 20 years ago. But we used to do it with a needle, and we used to mix it with lidocaine and saline to make this nice and thin. But now we have the products to do that. So what is here which is going to cause me problems? Well, you'll have your superficial temporal artery coming all the way from your parotid gland up just anterior to your ear, and then it will work its way through the hairline, and it will often anastomose with the supraorbital artery. It's given you a chance because it has a name. It's a superficial vessel. What layer is it in? It's in layer 3, in the superficial temporal fascia. What layer am I injecting in? Layer 2, and I'll show you how we identify that. The second vessel we need to be aware of, which can be pretty large in some individuals, is a vessel which runs through the lower temporal compartment here, supplying the orbicularis oculi muscle. That is your zygomatical orbital artery. And again, this can be superficial. You will have, coming from deep, from the infratemporal fossa, supplying the temporalis muscle, you'll have the posterior deep temporal artery, and you'll have the anterior deep temporal artery. And again, this is the one of consideration when you're injecting that one up, one over, or gunshot technique, because you're injecting into the muscle. You're not injecting onto the bone, you're injecting into the muscle. Can we have the blue pencil, please? Very importantly for you, and which is often not discussed, is a vein. We have a very important vein here which goes from the intermediate fat pad, and you can see it on some individuals just here, called the sentinel vein or the middle temporal vein. The middle temporal vein has caused major problems. It's actually caused 3 fatalities. 2 were with autologous fat and 1 was with HA. So we had cavernous sinus and a stroke, and we had a non-thrombotic embolism to the lung. And this is the middle temporal vein, so injected into a vein. You can find this very easy. It's 1 finger above your zygoma. So here we have your middle temporal vein. So we don't inject anything with a needle here. This is one of the reasons why the gunshot technique was so popular, because it avoids this vessel high up into this position. But it's very inefficient. It's around about, well, you will use almost 70% more product, and it's around about 55% less efficient on the literature, and you lose your product quicker. I'm going to go very different. I'm going to go superficial, and the only thing I have to contend with is some superficial veins. Now, the superficial veins are likely to cause a little bit of dilation. So for 24 hours, you say to your patient, either your veins are going to be looking like they're a little bit prominent. When everything is settled down, the lidocaine's gone away, it's going to go back to normal. Because we're using a very, very thin, spreadable product through this area. At the same time here, I'm going to treat a lateral eyebrow. And we're going to do this with a cannula. Do we have a 50 millimeter cannula? Please get out. And we're going to work our way into the temple, into layer 2. Okay, so layer 2 is your subcutaneous fat. Layer 3 is your superficial temporal fascia. Layer 4 is your innominate fascia, where your facial nerve will be. Layer 5 is your superficial deep temporal fascia. Layer 6 is your intermediate fat pad. Inside the intermediate fat pad is your middle temporal vein, zygomaticotemporal nerve. Layer 7 is your deep temporal fascia, the fascia which covers the temporalis. Then we have the temporalis at 8, periosteum 9, and bone 10. So we're going to inject in layer 2. Very, very superficial here. And the goal is to try to alleviate a little bit of this temporal crest, elevate and project and lengthen the eyebrow, and to restore some bitemporal width. That's the goal. Any questions? What we're finding now is that people are starting to do combination treatments here. We spoke about multi-layering treatments in the mid-phase for deep and static compartments and highly dynamic. And again, people are restoring the muscle with RHA4 or ultra deep, and then they're going superficial, depending on skin quality, with RHA1 or even RHA2 in some patients. So again, you have a portfolio product which is going to allow you to really find your way to get the best aesthetic outcomes for yourself and your patient. The other thing I like to do here is to try to keep things as clean and as sterile as humanly possible, is just to leave a little bit of the gauze lateral here as you're moving through. Okay, we're going to ask you to turn either just a little bit this way. Okay. Can everyone see that? Does that look okay on the camera? Yeah? Okay, perfect. Right, so just above your zygoma, you're going to find a position where you're going to reach this temporal crest here, and she's only got a very small temple, and we're going to inject very superficial here. Now, again, I'm going to give you a little hint and a tip or a trick. Can we have the sheath? Oh, perfect. What I'm going to do is to create a little offset here, just a little bend in the cannula. And the reason why I do this is a couple of reasons. Now you can see there's a little offset. This is really good for the jaw and for the temple because it keeps you superficial. It's pushing me superficially. Again, for the jaw, those patients with a big chest or big shoulders, you find it very difficult to manipulate around. Make a little offset, you can get everywhere just by standing straight. So this is going to keep me very, very superficial. I've had very good patients who've not bled on me today, so I've been very fortunate. So this is a product which is very, very light. It's only 15 milligrams. And again, this should just glide smoothly through the tissue. And when I get to the temporal crest here, I'm going to stop and then I'm going to show you the reasons why I inject superficially. Now, can you see the whole shape of the cannula? Yeah? If I was below the superficial temporal fascia, I wouldn't be able to lift the cannula up. I'd be stuck underneath the fascia. The fascia is tightly bound. So here I'm in layer 2. And what I'm going to do is deliver a little thread. And I want to show you the lift on the temple. Okay, you can see that lift straight away. It's not deep. You don't see that lift when you do a gunshot. You try to convince yourself you see a lift, but you don't. What I'm going to do here is stay in the same tissue plane with the patient, and I'm just going to fan below. And I'm being very respectful. I always take my time with this. And I'm not worried about any lumps or bumps, okay? Because I know I've done hundreds and hundreds of these cases, and I know how the product works, and I know how easy it is that it spreads out. So here you can see I'm starting to lift. You can see the irregularity of the product before I massage. And what I'm doing here is just filling the void below the skin in that subcutaneous fat that we know atrophies as we age. And it should be comfortable on your patient. It shouldn't be too painful. And I'm going to work towards the lateral eyebrow. Okay, Eva? Yeah, she's good. So again here, I'm at the peak of the brow. You can see I'm lifting up. She's had a little bit of toxin recently. Again, you can do this without worrying about toxin or problems with this, because my goal here is to increase the volume of the temple and of the lateral eyebrow without over projecting, because the aesthetic goal of a female temple is flat. We don't want to have a convexity because that's not normal. So again, we're just working our way. We've used 0.6 so far, which is a relatively small amount. Considering the area we're on, we can go very low here into this area. And it should be really nice and easy to mold. And what you will see is that dilation of the vein. But look at the eyebrow now with that massage. So the temple, if we do it nice and efficiently in the right tissue plane, even with a really light product, and again we'll use a little bit more product just into here, you can see what it's done straight away. This was pretty, I don't know how much deep filler you'd have to place here, but the problem with deep filler is the deep filler never fills where you need it to fill, down here. It stays in the muscle. And this is really important key to you. If you're not doing this superficial technique, then please try. You've got a very thin filler, which is, I think it's one of the most underused fillers we have in Teoxane. Garrett, can you clean the other side off for us? So I'm just going to place a little bit more filler just here, just at the lateral tail of the brow. And you can see the length of the brow now has improved. The temple volume is filled. And I'll just pop a little bit more in and do a little bit of massage. And then we're done. Is that simple treatment? Yeah, right product, right tissue plane, right result. So again, I'm just going to go back in. Remember to reassess your patients. You know, you've got product left over. You know, you always have that bit where you go, what shall I do with this? Sit your patient up and again, reassess. This is the only technique which will get you into that lower temporal compartment. Your gunshot technique will not get you into that tissue plane. And again, with a cannula here, it's going to help you massively. You cannot do this with a gunshot into this lateral part here. So this is RHA1. It shows you that even a very light product can give you some remarkable results if you understand and respect your anatomy, your aging, your assessment process, your product choice, and your technique. Okay, so I've used 0.8 total in this area. She needs a little bit of massage, and we're pretty much complete. Okay. Do we have any questions apart from the aspiration question? We don't want to fight. We don't talk about three things: religion, politics, or aspiration. Okay, those are the three things we never talk about, okay? Because we fall out. All right. So we're just going to massage. I'm going to get some post-procedure, which is great. The post-procedure cream that we have with my beautiful assistant, if she can get it out, is a combination of Nutrazine for the redness, Arnica, which is rubbish, okay? And Arnica has the same effect as prayer on bruising, statistically. So you may as well pray you're not going to get a bruise. But the great thing about this is it's chlorhexidine. And this is the thing where you can help massage and help with the issue of sterility in and around this area. It's really, really important. And it does give a nice little gloss to the treatment. And it allows you to sort of massage without creating any major trauma to the patient. So you can see it's starting to smooth out already. There is a little bit of irregularity there, but we know this at the very beginning with the vasodilation from the lidocaine and from the trauma with the cannula. But this, if we keep Eva around for the next sort of 30 minutes, you'll see that it'll be completely flat. And you can actually see what it's done. So right tissue plane, right result. And again, if you combine that with your gunshot technique, you should get a fantastic result. Okay, I think we're ready for lunch now. Arsene, is that right? Has he gone? Yeah, he's gone for lunch first. That's what bosses always do. Bosses go for lunch first. So you have to wait in a big line. Yeah. Okay, do we have any further questions? No, everybody's like, let me go for lunch or a cigarette or something. So I'd like to thank you for your patience and your time and your interest. I'd like to thank Gera, my beautiful assistant, who's 26, yeah. And everybody with the team spec, but more importantly you for coming here today and making the event such a memorable one for me. All right, so thank you. Okay, so we're going to lift your corners also, okay. Good.